This is Mitchell Zoller from Global Medical News Network. I'm at the annual scientific sessions of the American Heart Association. I'm speaking with Dr. Gordon Tomaselli from Johns Hopkins Medical Center in Baltimore. Dr. Tomaselli, now that dabigatran has been out on the market for a couple of months, what are some of the considerations you're giving to prescribing that to patients going on to an anticoagulant for the first time compared to the more conventional agent warfarin?
Mitch, I think for the first time in a number of decades we have another option to treat people who have risk of thromboembolic complications of atrial fibrillation other than warfarin. Drugs like dabigatran and rivaroxaban are drugs that don't require the same type of monitoring that warfarin does. Therefore, it's more convenient for people to take. And although these drugs are more expensive right now, the infrastructure that's required to do all the testing and interpretation of the blood testing for warfarin will ultimately make these drugs probably very comparable in cost in the long run.
And actually, I believe you were telling me before that you foresee with these drugs coming onto the market that the use of warfarin will really fade away to a very small portion of patients?
Yeah, I think so. There probably will be some patients who will need to be continued on warfarin, but the anticoagulation clinics that exist are probably going to dramatically decrease in size, and there are going to be fewer and fewer patients ultimately on warfarin and more patients on these two drugs and other therapeutic options that are in the pipeline that affect the coagulation cascade without requiring the same kind of monitoring and the same sensitivity to changes in medications and diet that warfarin does.
One other question I had, I realized that there are two different drug classes, dabigatran being a direct thrombin inhibitor, rivaroxaban being a factor X inhibitor, but the rivaroxaban study that's been being reported this morning was in a particularly sick population, and what do those findings tell you a bit about how these drugs can be used?
The fact that this drug was non-inferior, and depending upon the type of analysis, may be superior in a patient population that has a high CHAD score. This is a score that tells us how likely somebody is to develop a blood clot that could cause a problem like a stroke. Really means to me that in the sickest of the sick population who have these problems, that this drug's at least non-inferior. It's always dangerous to extrapolate to other populations, but my guess is it's going to be effective in people who have lower CHAD score but still require anticoagulation therapy to prevent blood clots and their complications.
Mm-hmm. So really a useful option across the range of
Absolutely. I anticipate it's going to be a very useful option across the range.
Thank you very much, Dr. Tomaselli. For Global Medical News Network, this is Mitchell Zoller.